So actually, there are two sections to this presentation. The first is just trying to understand what kinds of different research questions could be there and what are the different types of epidemiological study designs which would be mostly appropriate for these questions. And then we are going to take up one example and see what different scenarios could crop up wherein the research question changes and alongside the change in the research question, the study design also alters. So the first, I think half an hour, we'll just try and understand the research questions and the appropriate study designs. So assuming that all of us know the basics of the study design, we will move ahead. So the first, these are common questions which we come across in our dissertation or different small projects which we do. So the common themes which are addressed through these questions is what I have taken up. So first could be as simple as finding out the disease burden and the factors associated with those prevalent cases. So if your question is about trying to understand what the disease burden is and what are the factors which are associated with the cases you have identified, then you will go in for a cross-section study. The characteristic feature of which is that there is a single interaction between the investigator and the respondent. It is the easiest study to do, and majority of the studies conducted for the thesis or for the small projects are cross-sectional studies. So the epidemiological measure which we estimate by using such studies are the prevalence rates or the odds and the odds ratios. An example of this kind of study would be cross-sectional study of prevalence of blindness and the socio-demographic factors associated with it. So a one-time interaction, the investigator will conduct a survey and identify people with without blindness, which will help them to estimate the prevalence of blindness, and along with it, data on socio-demographic factors or characteristics will be collected, which will be analyzed. Another research question which could come up is what is the risk of a disease in a particular population? Or more commonly, what we do is try and identify the risk factors for a disease or even for outcomes, right? So various kinds of outcomes. So when we talk of risk, the ideal study design would be to conduct a cohort study because you need to calculate the incidence in those studies, and you need to identify the new cases which have occurred in a baseline population which is free of the disease. So you would need to identify a cohort and follow the cohort to identify people who have transited from the non-disease to the disease state. You can also conduct a case control study. Now, to identify risk factors, you can also conduct a case control study wherein you will calculate the relative risk. If the outcome you are studying is a rare disease, the odds ratio will be equivalent to the relative risk. And if the disease is common, the only limitation is you cannot equate the odds ratio with the relative risk. You will have to report and interpret your estimate as odds ratio, which are a bit difficult to understand compared to the relative risk. That is the only issue here. So when you want to find out risk factors, you invariably have to make comparisons. And one of the ways to make the comparisons is to report differences. Another is to report ratios. So the commonest thing which is noted is reporting the ratios, either odds ratios or the risk ratios. An example of this kind of study will be cohort study to assess anemia as a risk factor for low birth weight children, babies. The third scenario which I'm taking up is where you want to find out effect of various interventions. That is, usually we say we want to measure the effectiveness of the interventions to reduce the risk of disease. Now, such kind of research questions invariably will require intervention studies. So it could be randomized. The ideal, of course, gold standard is the randomized controlled trials. So again, you will calculate the incidence rates and the relative risk or the risk ratios for such kind of studies. An example of this kind of study would be an intervention study to assess the effectiveness of iron supplementation to prevent low birth weight. The third category of the questions which are not taken up so commonly is where we want to measure the effectiveness of interventions, but this is to see whether the interventions reduce reduce the length of the illness. There is some mistake I have made there in editing, but to reduce the period of illness or to lengthen the survival period. That is what you would want to do when you want to study time to event, means time to death or time to recovery. That is what you are interested in. Now, when you want to do time to event is your outcome of interest, you will invariably do a cohort study or a intervention study. You will calculate hazard ratios in these kinds of studies. So an example of this study would be study the effectiveness of a new drug in improving survival of patients with breast cancer. So the duration of survival, the 5-year survival, of the period of survival, whether it is less or more without intervention, this is what we would be interested in this kind of study. The next one is usually which is done in the departments which are involved in diagnostic workup, say the biochemistry or the microbiology, pathology departments, where they are interested in assessing the validity and the predictive values of a new test or a tool. So again, this would require a cross-sectional study wherein both the new test as well as the gold standard test is offered to the participants, and you then assess the validity and the predictive value of the test against the gold standard. An example of this kind of a study would be a cross-sectional study to assess validity of a new screening tool for breast cancer. So these are, I thought, some of the common scenarios. And then one of the critical points which decides your study design is your research question. So we need to understand what our research question is, have a clarity about our research question, and then based on the feasibility aspects, we will have to choose an appropriate study design. Do you have any questions till now? Because we will now see some examples and we would discuss what would be the appropriate study design for some of these research questions. Do you have any questions till now? Because I have gone a bit fast, I know. But if you want us to go back and see a particular outcome and what kind of study design, we can do that. Anyone has any questions? Ajit? Yes, please. Yes.
Ma'am, suppose if I am doing interventional study without a control, so which study design it is?
So most probably you are doing a before-after study, right? You are thinking of doing an intervention. You are trying to measure the outcome of interest before the intervention. You give the intervention, and in the same person's post-intervention,
Yes,
that is a before-after, also known as a quasi-experimental study, a before-after study,
yes,
right?
ma'am.
But
Yes,
this
ma'am.
study, remember, has a limitation, a very big limitation, because the circumstances in which you gave the pre-test, right? And the circumstances in which the post-test was conducted, you have no control on those circumstances or factors. So there is no guarantee that those factors remain the same. So usually it is the randomized control, which blinding with allocation concealment, which is the concealment which is practiced, a parallel design is a gold standard. But there are circumstances where you cannot implement the gold standard trial design. There people do the pre and the post test, but ideally it should be avoided. Are you getting me?
Yes, ma'am. Thank you, ma'am.
Welcome. So we'll just go and discuss a few questions so we understand whether we have really understood the the preliminary part, which the introductory session. So we have to just tell what will be the study design, the measure of frequency, and the measure of effect in these the questions which I have put forth in this slide. And the second part we will neglect for now. So the first question is, so I would really want volunteers to think and to tell me, at least to begin with, what study design would be appropriate for these questions, right? So is wealth index associated with childhood malnutrition? That is family wealth index of the family associated or household associated with childhood malnutrition. So what would be an appropriate study design for this research question? Anyone would like to answer? Yes,
Yes, ma'am.
yes,
It might be a cross-sectional study.
yes, you are right. This will be a cross-sectional study, right? Now, why do you think a cross-sectional study is appropriate?
Uh, because we need to know about the childhood malnutrition, and then the
Okay.
associated factor is the wealth index. So childhood malnutrition, there is a one-time approach will be there. So we will collect that one time only, and then we try to see the associated factor, that is wealth index, whether it is associated with that or not.
Yes, so you are right. So what we are interested is understanding the association between the wealth index and the childhood malnutrition, and a cross-sectional study would be sufficient for us to do this. Just a minute, I'm just trying to get a pen and I'm in a bit of a problem. What is the issue? No, this is not. Let it be. So you are absolutely right. I think it was Dr. Dhaval, right? So Dr. Dhaval has
Yes,
given
ma'am.
a right answer that we would be interested in conducting a cross-section study. Now, what would be the measure of frequency and measure of effect in this study? So I'll just help you out because I don't know, if you want to try, you can try. For the outcome in childhood malnutrition in a cross-sectional study, what would you measure?
It is the amount of the childhood malnutrition. That is the prevalence of malnutrition.
Yes, you are absolutely right. So you will actually measure the prevalence of malnutrition, right? And then
Yes.
you can measure the prevalence rate, the prevalence ratio, as well as the odds ratio in this cross-sectional study to study the association between your exposure and the outcome. Very good. The next research question is, does low birth weight increase the risk of metabolic syndrome in adulthood? So anybody else would like to take up this? What would be the appropriate study design
Cohort,
for
ma'am.
this research
Cohort
question?
study, ma'am.
Yes, cohort. Who said that?
Cohort study, ma'am.
Yes, Priyanshu. Can you elaborate?
Ma'am, because we want to find the risk of metabolic syndrome.
Hmm.
We want to measure the risk of metabolic syndrome in childhood.
Okay. So how would you go about doing the study?
Ma'am, cohorts, I'm not getting your question, ma'am.
So you said cohort study. What is your exposure of interest?
Exposure is, ma'am, low birth weight.
Right. What is the outcome?
Outcome metabolic syndrome.
Correct. So you want to do a cohort study means it is a follow-up study, right?
Yes, ma'am.
So how would you do the follow-up? From where to where? From which point to which point?
Ma'am, from exposure to outcome
So from low birth weight to, oh, I'm sorry,
to metabolic syndrome.
just a minute. I am doing something out here and Just bear with me for 1 minute. Yeah. So what you said was right. But what is the issue with the study design you have mentioned? Right?
Ma'am, loss
Okay,
to follow up.
from birth to the development of metabolic syndrome. What is the common age group in which metabolic syndrome occurs? It will occur either in adulthood or in later in age, right? So it will be a very long period of follow-up. Agree?
Yes, ma'am.
So it would be difficult, if not impossible, to do the study. From the birth to the occurrence of metabolic syndrome, it will be a very long period of follow-up. So what is, if not the cohort study, because now you're looking at the association again of two variables, you have to do a comparison. So there are limited options you have, isn't it? A cross-sectional, a case control, a cohort, or an intervention. So which study design would be appropriate for this research question?
Ma'am, we can also do comparative cross-sectional study. Can
Cross
we do?
sections, no. A cross sectional study would mean that you will have to collect data on all the individuals and then categorize people according to presence absence metabolic syndrome, which is possibly not necessary. What you would ideally do is a case control study. So you would identify individuals with metabolic syndrome in the present time. You will identify individuals without metabolic syndrome, and assuming that there is good record keeping and all these people have records of their birth weight, you will get information or data on their birth weight. That is the exposure, and you will calculate an odds ratio. You will not be able to calculate the prevalence rate or the incidence rate here. You will be able to calculate the odds and the odds ratio. Are you getting me, Dr. Priyanshu?
Yes, ma'am.
So it is not just the research question, but the feasibility is another angle which you should remember, and then think for other alternatives to find the appropriate study design. The third research question is, do obese pregnant women have a higher risk of cesarean section deliveries? Anyone would like to take up this question? So Dr. Sampath is saying cohort study. Can you explain a bit further, Dr. Sampath?
Hello, ma'am.
Yes, Sampath.
Hello.
Yes, Sampath. Why are you saying that you will choose a cohort study? It's a correct answer.
Ma'am, here in this study also, our exposure is obese pregnant woman and outcome is risk of cesarean section deliveries. So that's why it's a follow-up study. So a best suitable epidemiology study is a cohort study, ma'am, in this case.
Yes. So compared to the previous study, the follow-up period maximum is going to be how much? 9 months, right? So this study is doable as a cohort study. You identify women, pregnant women who are obese or non-obese in their first trimester itself or at baseline, and then you do a follow-up. And the follow-up period is doable, is feasible. So you can do a cohort study very easily for this research question. So again, you're looking at your question, you're looking at feasibility, and you can decide on your study design. Now, the third question is, do patients of complicated COVID-19 receiving a novel treatment have better treatment outcomes? So what would be the study design for this particular research, ideal design?
The interventional study.
Yes. So intervention study, somebody mentioned randomized control trial, very much true, because we are looking at the intervention, a novel treatment among COVID-19 patients. So we would like to randomize these patients into two groups, one receiving the standard treatment, one receiving the novel treatment, and of course then follow them up for outcomes, for favorable and unfavorable outcome. So for this question, an intervention study is a must. The next question is, does the new chemotherapeutic regimen improve survival rates of patients with breast cancer? Which study
RCT, ma'am.
Yes, RCT, correct. But what will be your the next question? What will be your measure of frequency and measure of effect? Now you have to contrast this with the previous question. In the previous question, my outcome was probably, say, unfavorable and favorable outcome. And in unfavorable, I'm talking in terms of mortality. So what is the mortality rate in those who were given the standard treatment, in those who were given the novel treatment? Or the severity of the disease, or the complications, presence or absence of complications. What would be my outcome of interest in the last research question? So this is an example of time to event, right? Because I'm talking about survival. So what I'm interested here is whether the period of survival increases in the new chemotherapeutic regimen compared to the standard treatment, whether the people are surviving longer. So here, my study design, very rightly said, is an intervention study, but my outcome is time to event. So I will calculate hazard ratios as a measure of effect. While in the previous example, most probably I will calculate relative risk or risk ratios, relative incidence rate in both the groups, and compare them as a ratio, that is a relative risk. Here, I will calculate the hazards and the hazard ratio. Now, I will give you another question. If there is a new point of care test for diagnosis of, say, malaria, which is where the results are given quickly, and it is a non-invasive test, how would you design your study? Which design would you use to calculate the validity, that is the sensitivity and specificity of the test? For some of you all who have joined late, some of those who joined early can answer.
Cross-sectional study, ma'am.
Cross-sectional.
You have mentioned in the
Yes, correct.
Yeah.
So you would do a cross-sectional study in which you would use the gold standard as well as the new test in all of these participants, and then by 2x2 cross table, you would calculate your sensitivity, specificity, and your predictive values.
Yes,
So
ma'am.
we have an idea about what kind of study designs we could think of for different kinds of research questions. And you always have to consider the feasibility aspect, which is equally important. So this actually ends our first part, the introductory part for understanding how research questions are helping us decide our study designs. Now, actually, I am going to discuss with you all a very specific topic, which I really wanted to do it solo, but I thought the introductory part was equally important, because when I went through the list of participants, I thought some of you really expected me to do something about the basics of the study design and how the research question can influence the study designs. Now, this photograph which I am showing you is actually the inauguration of the virtual dissection table in the anatomy department of Grand Government Medical College. And after this inauguration, after some days, the head of the anatomy department, Dr. Deepak Joshi, superannuated. And on the day of superannuation, our new dean, he expressed his desire that the institute and especially Department of Anatomy could take up research on the tools, the equipments which the department had gone. Apart from the dissection table, there were many other things which came in the department. So what I thought was that if this is what the head of the institute is proposing, what could be the different kinds of research questions which could be taken up? The scenario is that there is a new virtual dissection table in the anatomy department. So can you all tell me who would be the stakeholders who would be interested in research outcomes for this scenario? Can you tell me the stakeholders?
Ma'am,
Student, ma'am.
Yes.
ma'am, the ma'am, the virtual table, the person who is the companies who are creating that, they would be interested in research, funding this research.
Why?
Ma'am, they are in investing in that. They are the person. They are the company who is manufacturing this virtual table for dissection. So
Correct.
if thank you, ma'am.
Yes, a very good answer actually. I expected this to be the last, but this is first.
Thank you, ma'am. Thank
Yeah.
you so much.
Anyone else?
Uh, the healthcare professionals who are actually involved in this, the hospital which is donating the table will be a stakeholder, and the students who are getting benefit from the innovation will be the stakeholder of this.
Correct, correct. So the students are important stakeholders, right? Any
Ma'am,
other?
other medical colleges or other hospitals can also be
Interested?
stakeholders.
Okay. Yes, they would be interested in knowing the results, right? So the students, of course, are important stakeholders. The teachers are important stakeholders. They would want to know something about the table. Then the department, which is putting in funds, somebody said that to procure the table, they would be interested in some research questions. The manufacturer, somebody mentioned, and Ajit also put forth another angle. Other medical colleges would look up to the results of your research to decide whether to replicate it or not. So now, if these are the stakeholders, so one thing when you are taking up a research question would be, okay, I'm interested in this particular topic, but who would be interested in the results of my research, and how would they be interested? Right? So this is something which should also help you decide your research question, is what I'm trying to tell you. So, okay, you know that there is a new virtual table out, in the anatomy department, and these could be the stakeholders. The next question actually is telling me about, try to tell me about what could be the research questions. So, okay, these are the stakeholders. Now you have to frame the research question. So, what could be the research questions?
How can we can do a comparative study between the innovative table, virtual dissection table, and routine dissection, and see the outcomes of the retention in the students who are actually participating in the study.
Okay, so you are
Ma'am,
saying, 1 minute. So what you are saying is, you are, please repeat. You are first, you said, are interested in the learning outcomes. Retention, you said, right?
Yes,
So the learning outcomes. And what did you say before that?
we can do a comparative study between routine traditional methods which are actually followed with this innovative method which we have followed by far,
Okay,
comparing its standards.
right. So you said that we would have the routine method, the traditional methods, and the new virtual dissection. You want to compare, right? So you want to look at the effect of the virtual dissection table on learning outcomes compared to the traditional methods. Yes, somebody else was saying something.
uh, ma'am, the same thing only.
Okay, yes. Any other research question you all can think of?
We can also do a cost-effective analysis, map. How much actually traditional method is costing to the administrators, and how much the innovative method is actually costing to the administrators, so that how much beneficial is it with the investment we provide for them.
Excellent. Yes. So cost effectiveness is something people would be interested in. Anything else? So this, especially the department which is funding, the medical education department would be interested to know whether the provision of this dissection table is cost effective or not. The teachers, the students would be interested to know how is this dissection table helping improve the learning outcomes. Any other question you can think of?
Ma'am, in the comment section, we have gotten effectiveness of virtual dissection table and satisfaction of students with the.
Okay, very good. So you're talking about, sorry, satisfaction, right? Anything else?
Ma'am, does it help them in their productivity? Like, is the marks, is the academic performance being enhanced?
So that is this learning outcomes. So I think you have given a very good list of the research questions. I'll just see who all are there so I can call out. Okay. So the first research question, now you all have mentioned nearly all the research questions I thought of. One research question was, what is the effect of virtual dissection on learning outcomes in anatomy subject compared to cadaveric dissection among first year MBBS students of a government medical college in a metropolitan city of Maharashtra? So this is how probably possibly you would frame your research question. So many of you all must have thought of this research question, right? When I spoke, I don't know whether Dr. Ashwini is still there because I saw her some time ago. Dr. Ashwini, are you here? So the professor and head department of anatomy from Grant Medical College was here some time back. But what happened is when I thought of this research question, like many of you all did, and I spoke to her, so she told me that what the department is looking at is that the virtual dissection is an add-on to cadaveric dissection and not a replacement to cadaveric dissection. So what the second point I'm going to tell you is that when you're thinking of your research question, you have to talk to the stakeholders. You have to discuss the topic of interest with the stakeholders who would be interested in the outcome or the results. So when I spoke to her, keeping in mind this research question and depending upon the response was, we are not considering the virtual dissection table to be a replacement for cadaveric dissection, but a complement to our routine traditional method. Would that influence your research question? Or would you still do the randomized control trial like you had planned before? So I give you some time to think. Right? Because when I thought over this, what I thought was there were two possible research questions now. I have to drop my earlier research question. What are the alternative research questions which come to mind? One is, does adding a virtual dissection table to the standard cadaveric dissection affect learning outcomes among MBBS students? So this, your research question will change. Now I know that not all of us are from the anatomy department. There could be participants in this session from different departments, but what we can do is to replace the virtual dissection table by something we are interested in. I know that there are representatives from the surgery department here. So in the surgery department, we have robotic surgery which has come in. There could be some other departments where there could be some new equipment, some new technique in training, teaching which has come in. So you can think of those alternatives in place of the virtual dissection table. So when I told you the demand of the interest of the stakeholder changes, your research question changes. So the second alternative research question
बहुत सही बता रहे हैं भाई, बहुत सही बता रहे हैं.
was, do the learning outcomes in anatomy department among first year MBBS students differ according to the sequence of exposure of cadaveric dissection and virtual dissection? Can anyone explain to me what I'm trying to say here?
Directly showing the anatomical dissection of the cadaver to the MBBS students may not be that effective. Before showing the actual dissection, we can show them the virtual dissection, which may enhance the 3D perception in the students. Followed by, we can start the normal cadaveric dissection, which increases the learning outcomes in the students.
Right. So see, in here what I'm saying is, okay, I will do what I'm doing. I'm just going to add this new thing and see whether it changes the scores. Here what I'm saying is, the teacher is asking me, do I first teach the student on the virtual table and follow it up with a cadaveric dissection? Or should the students first do cadaveric dissection and then I expose them to the virtual dissection table? What sequence should I follow? Right? She has told me that they are looking at it as an add-on. So one possible thing is, do I do it before or after the cadaveric dissection? So that is how the research question could change. Okay. And then what are the other research questions? Now, this is another research question. Somebody interestingly did mention satisfaction, but you could also look at the perceptions, the experiences of the students, the teachers regarding virtual dissection table compared to the cadaveric dissection. This is a very different research question where you are interested in perceptions, experiences, and satisfaction, and not just the learning outcomes, the retention, or other aspects of learning. Here you are interested in the perceptions, experiences, and level of satisfaction. Do you all agree that this is a different research question?
Yes, ma'am.
Thank you, Ajit. Then somebody mentioned again that cost effectiveness. Yes, compared to the cadaveric dissection, is the virtual dissection cost effective in teaching anatomy to the first year? So those who are funding the department would want to know how cost effective is this new tool which is being provided to the medical institution. So these were some questions which many of you were able to identify correctly. So we know the research questions, and we have also actually thought of the study designs, but still I would like to just go and revise. So you already said that a randomized controlled trial is what you would do here, right? What would you do for the second? This question, the second one, adding virtual dissection table affecting learning outcomes. What could be the design you would choose here?
Case control study, ma'am. One group we will give them with virtual dissection table and the other group with the normal. And we'll check whether.
I would still stick with RCT, the gold standard here, which is doable. So what I would do is one group, I would say, okay, you read your books and you go in for cadaveric dissection. Another group, I will say you go to the virtual dissection table first and then go in for your cadaveric dissection. And then I would look at the outcomes. Okay. Because this is an add-on. I want cadaveric dissection for all. And I want people with and without exposure to the virtual dissection table. So I would still go in for an RCT. What would you do for the third research question, where the teacher is asking you what should be the sequence of exposure? Should it be first the cadaveric, or should the first one be the virtual dissection?
Here case control. One will give first virtual dissection table, at the same time other group as this convention.
Okay. Any other answer?
Ma'am, we can do a quasi-experimental study for before and after.
Okay.
You can also do that.
Any other?
RCT.
Okay. Any kind of RCT anyone can think of? This is a hint I'm giving.
Non-random.
A crossover design.
Who said that?
Ma'am, Apurva.
Great, Apurva. You are right. So a crossover randomized control trial is the study design for this question. And we will see how this question requires a crossover RCT. Because here we are looking at sequence and we can study both the sequences in a crossover RCT. What about the fourth research question?
Qualitative study.
Mixed method or qualitative?
Yes, mixed method. Yes, ma'am. Mixed method will be better than qualitative.
Yes.
Only qualitative.
Yes, so your answers are actually right. So perceptions, experiences, satisfaction, that you would want to study your qualitative study. And for cost effectiveness, you would do a cost effectiveness study, which is a type of a head technology assessment. Right? There is another study design which I will also discuss because one of the participants, I don't know whether Nishant is here. Is Nishant attending the class? So, okay. So the first question, we'll just try and understand each of these questions so once again I am saying, though I am repeatedly saying virtual dissection table, you can very well think of an alternative which you are interested in or you know of in your department or in your institution. So the question is about the learning outcomes, whether they are different, and assuming that, okay, we still want to go ahead with the RCT, the study design is randomized control trial. The study population will be the first year MBBS students of the medical college. The intervention would be, what would be the intervention? The virtual dissection table. The control would be the cadaveric dissection. You will randomly allocate the students either to the intervention or the control. The outcome would be the learning outcomes of these students, which you would assess either by a test, a written test, an MCQ test, or a practical examination. And then you would do your analysis to find out the scores, whether the scores are different. So can you tell me, just let us focus on the outcomes and the analysis, because these two are related to each other. What are the different kinds of outcomes you can think of in this study, which you want to compare between the two groups? When you want to compare between the two groups, what do you compare? You will compare summary statistics. So you will get many values for the children in the intervention group, many values for the students in the control group. You will summarize them in some way and you will make the comparison. So what is that summary statistic which you will show in your tables and you will compare?
Ma'am, the receptive power, like retention power.
Yes, but how would you measure it? My question is, how would you measure it and summarize it? So, and say, what would you say for the intervention group and the control group? How would you report it?
Scores in the exam.
Correct. So scores, you would take scores for each student, and then what would you do? Marks or scores you will give each student, right? So each student would get a different score or a different marks. How would you summarize it?
Mean and standard deviation of the scores.
Yes. So one option is say mean and standard deviation for the intervention group, on virtual dissection control group, on cadaveric dissection, and you would compare the mean and the SD in the two groups. Any other summary statistics possible? You would
Ma'am,
also,
if
yes,
data is skewed, then we can take a range or interquartile range.
And assign grades and group
yes.
the
Even if
scores.
you assign grades, scores, an option, as somebody mentioned, it is a skewed distribution, not normally distributed. You will report median and interquartile range or range. Anything else you could do? Could you have a binary outcome?
Yes, ma'am. Pass or fail, or we
Yes.
could keep a
All these,
cutoff and.
very good, Apurva. So all these scores, you can have a threshold or a cutoff above which you say people have passed and below which you say people have failed. And you convert all these numbers into a binary pass or fail. Now, why it is important to understand all these options which you have, because all of this decides your analysis. Now, supposing you say you are reporting mean SD, here invariably you are assuming normal distribution. So, what kind of analysis is possible?
Parametric test can be used.
Yes. So, what are the parametric tests you would use here?
T-test can be used.
Yes.
Ma'am,
So,
paired t-test.
Yes.
Paired
not,
t-test, ma'am.
you would use a t-test, but not a paired one actually, because you have two different groups, right? So, you would use an unpaired t-test. If it would have been a before-after study, same group of students before-after, you would have done a paired t-test. Agree?
Yes, ma'am.
Now, supposing you you tested, you found it's not normally distributed, you report it as median interquartile range. Then what would you do? You would have to use the non-parametric test. Agree? The non-parametric test. And we are not going to go into those details. And if it is pass fail, if you have been decide to convert it into a binary, then how do you analyze?
We can use a chi-square test.
Yes, you can use a chi-square test. If you go for ratio, then if you are assuming normal distribution, you would go in for linear regression here. If you are converting into a binary variable, outcome variable, you will go in for a what kind of regression?
Logistic regression.
Yes. So here you will go in for logistic regression. Here you will go for the linear regression. And here, unfortunately, you will just have to do single bivariate analysis. So your analysis depends upon your outcomes. There are different ways you can convert the outcomes and from one form to the other and choose your way of analysis. Okay.
Ma'am, we have a query in the comment
Yes.
section.
Yes.
With the outcome tests that we were discussing, one has mentioned that most probably the sample size will be more than 30 in a case like this. So the test we will be Z test possibly. Is that correct, ma'am?
It is correct, but see, when the sample size is less, t-test is a must. When the sample size is large, you could use the t-test or the z-test, both. So the t-test can also be used for large sample size. For
Excuse me,
small
ma'am.
sample size, the z-test should not be done.
Excuse me, ma'am.
Yes.
I have the doubt regarding the same question, but when we are using statistical softwares like SPSS, we are not able to generate such difference like Z test and T test. Is there any way to generate Z test and T test in using SPSS?
Which test?
The same test, ma'am. When we are using SPSS,
Yes.
it is showing as either paid test or unpaid test, and there is
Yes,
no SS
unpaired
specific
test.
match.
Unpaired test, t-test, you can use no here, unpaired t-test.
But it is not showing as a Z test and T test while using SPSS for statistical analysis.
Yeah, because see, for small sample size, you can use t-test. For large sample size, you can use t-test. So when you can use t-test, why use z-test?
Okay,
For
right.
quantitative data, no? You can use t-test for small or for large sample size. Get it?
Yes, ma'am.
Yeah. Now, the next question which I want to ask you is, okay, randomization we are saying, but the teacher tells you that, see, we have batches, pre-formed batches, and I can't do randomization. Now, it will create a lot of complications. Randomization means what? All the students have to be randomly allocated to the two groups. Roll numbers are assigned, batches are made. So they say batches are there, we will go according to batches. So what are the options now? The option is possibly a non-randomized trial. So how to handle this situation? In a non-randomized trial, what are you worried about?
Bias.
Bias. One is selection bias. What is the other problem? That you are not able to handle confounders, right? So what you would possibly do is you would collect the data on the confounders and try and adjust it in the analysis. So what is the difference in the control of confounding in randomization and say in regression and in your analysis? Which is better and why? My question again, I'm repeating. There are many confounders in this association. Can you think of at least a few confounders where the exposure is the type of dissection, outcome is the learning outcome? Can you think of any confounders? Last class we discussed about confounders.
based on students' merit, there will be a
Right?
confounding.
Correct.
And
Merit, yes.
teacher allotted to the specific batch.
Okay. Or even say the interest and the exposure to these various kinds of devices, right? Those could be, so there could be confounding here also. So agreed that there is confounding. The next question is, what is the difference in the handling of confounding in randomization, by randomization, and by handling of confounding in regression in analysis?
Ma'am, in randomization, we are taking care of the unknown confounders also.
Great, Apurva. Right. So you are able to control for the known and the unknown confounders. So it is far superior randomization as against doing any kind of other adjustment in your design or analysis level. The next question is, you will have to collect data on the confounding variables if you want to adjust it in the regression. Is it necessary to do it for randomization? I'm repeating my question. You know that the academic achievements of the student, the exposure to these IT devices, they are potential confounders. You want to collect those data if you're not randomizing and you want to adjust them in regression. Will you collect those kind of data on those variables if you're doing randomization?
Ma'am, we can
No,
collect the
ma'am.
data, but it's not necessary to analyze it later that way.
Okay. Anyone else?
Ma'am, no need for collecting that. If we do like that, like randomization will not be.
No, you should still collect the data, because remember table 1 of any randomized control trial. You must have of course seen the table 1, right? Table 1
Yes.
of a randomized control trial is where you report how these confounders and different variables, whether there is a balance between them in the two groups. So how successful you have been in your randomization. That is, table 1 is a point where you prove that yes, I have done randomization and it has been successful. So you have to still collect data on confounders. That is the take home message, right?
Okay, ma'am.
Now, this is a study, actual study. Now, again, what the other thing I think I want to tell you is that every time you feel that you are doing something new, innovative, when you look at literature, invariably you will find that people have already done all kinds of studies. So this study also has been done. Now, this is the study where students were randomized. They were randomized first into class A, class B, class C, and then within the class, they were randomized into virtual and the cadaveric dissection. And then a test was taken and then scores were assessed. So this is a simple randomized control study. And this is how they are reporting their findings. So these are known as violin plots. At the end of the class, if anyone is interested, we will discuss these plots. So very interesting plots. The thing I'll just draw your attention is to the central white dots, which are there, these dots, and the red solid horizontal line, right? So the dot is the mean and the horizontal line is the median, and this particular violin plots, when you compare it with the test of significance, these star marks here, they are telling you about the significance. A single star tells you that the p is less than 0.05 and this is less than 0.001. So what do you think is these violin plots are telling you? This I'm telling you is the average amongst those who have undergone or who have taken up virtual dissection, and this is the average of individuals who have taken up cadaveric dissection. So how do you interpret this plot? You are comparing these two values, and the test is saying it is significant.
Virtual students scored more than donor
Yes.
in class
So
in quiz
yes,
one.
correct. Yes, correct. So the scores which are there, the scores of students who took up virtual dissection was significantly more than the scores who took up cadaveric dissection. This was for class A. For class B and class C, there was no significant difference. While for overall, for all these three classes, there was a significant difference where you can see this gap which is there. So the virtual dissection more scores, the average score is better than the donor. This is what the findings are for a randomized control trial. So depending upon the feedback of the stakeholder that the virtual dissection is not a replacement, a complement, this is what you will do. You will have, again, this kind of study has been done where students are told to do the routine stuff, read the textbooks and go in for dissection, or the intervention where first the gross dissection, then the cadaveric dissection, and then give them a test and look at the average scores and do a comparison. The previous violin plot there, the t-test was used by those authors for getting the p-values. The next question, where the interest was on the sequence, right? The interest was this sequence of exposure, whether it is cadaveric followed by virtual or virtual followed by cadaveric. So how would this study be done? So you have the population, the first year students. How would you go about doing this crossover? What would you do actually?
We can separate them into two halves.
Yes. So one will get the cadaveric.
One will get. Yes, ma'am.
Then what?
Hello, ma'am.
Yes.
Ma'am,
Yes.
there will be two groups. One will get a cadaveric dissection, and second group will get a virtual dissection. And there will be after that a washout period. And then we have to like exchange. Like the first group will get a cadaveric, and the second group will get a virtual dissection, and we will compare.
Correct. Right. So this is what you would do. So that both these dissection tables are handled by all the students in different sequences. That is what you would do to assess the sequence of exposure. So this again, yes.
We can't do it in this way. In one group will be initially giving the visual dissection and followed by cadaveric dissection. We'll be showing them in the visual dissection the organs followed by cadaveric dissection. And in the other group, cadaveric dissection followed by visual dissection. And we can see how much they have retained in the.
Yes, that's actually what we are talking about. Actually, that is what is happening here. Just if you think very simply.
Oh.
Okay. Because we have now, what you are talking of is not in terms of intervention and control. We have just replaced the words intervention and control. So one group is doing one thing first and the other thing afterwards. The other group is doing the other way. It's as simple as that. Okay. It's the same thing. What you are saying is also the same thing. So the same study which we did previously, they have done this. That is, you give the one kind of dissection to one group and then follow it up with the other kind of dissection and vice versa. So because this study was a part of that original parent study, they have done it in a complicated fashion, class A, class B, class C. Overall, it is the same as both the participants have rightly described. So one gets virtual first, followed by the cadaveric, and the other gets cadaveric followed by the virtual. Now in this violin plot, again, the tests which was done was the same t-test. Here again, it was seen that the sequence did not matter. None of these differences were statistically significant. So the sequence of the dissection did not bring about any change, but the entry of the virtual dissection did improve the average scores vis-a-vis the cadaveric dissection alone. That was what was the finding of this particular study. Now the question is, when this study is reported, and as far as the department is considered or other colleges are considered, there will be some issues with generalizability, right? So this has been done in Grant Medical College. It's done in a single institute. The situation, scenario, facility, students coming there, teachers, it is very different. Ours is very different. So these findings are not applicable to us. This will be one limitation. And another is if the department gets such results and they are told that adding a virtual dissection table improves the learning outcomes of students. The department decides, okay, then we will buy more virtual dissection tables and give it to more medical colleges, but we'll not be able to do it in one go. We have to do it in a phase-wise manner. So every 3 months, 6 months, a new table will come and it will go to a medical college. What will happen? If you want to now expand the study to a multicentric study, you want to enroll more medical colleges in the study. What are the challenges you see? So they say that next 3 years, from 2016 onwards, for 2 or 3 years, every 6 months, a virtual dissection table will be purchased and will be given to some medical colleges, a group of medical colleges. And in this way, we will try and cover as many medical colleges as possible. Do you see? Now they want to keep on assessing, doing the study, because this doing the study in one institute is not acceptable. So the study has to be replicated in more institutes. But the scenario is the department is saying we can't give the virtual dissection table to all the institutes in one go. We will do it in a phase-wise manner. So in this scenario, a very interesting study design which can be taken up is known as the stepped wedge design. Can anyone just have a look at this table and tell me what is this stepped wedge design?
Initially, there is more of cadaveric dissection, and gradually they start, but then everything converted to cadaveric virtual dissection.
Yes. So what happens? Every 6 months, the department is purchasing and giving it to some 2 or 3 medical colleges, and there is a shift from cadaveric to cadaveric plus virtual dissection in a phased-wise manner, stepwise manner. One by one, all these groups of colleges get the cadaveric dissection, add it on as a supplement to their cadaveric dissection, the virtual dissection to the cadaveric dissection, right? Because there was this student actually, I don't know whether he has come, Nishant, who had asked me about the possibility of a stepped wedge design in academic study. This is an example where you can do the study. This is a stepped wedged randomized control trial. So still it is a randomized control trial. The groups which you select are selected randomly. Which are the groups which are going to get virtual dissection? That is done randomly, and you go on adding the new set of colleges every 6 months. You go on doing the assessment of the learning outcome at baseline and after every 6 months. What are the advantages of this particular study design? One is that you have a bigger sample size, so the power of the study is increased. The generalizability of your findings is more because all kinds of medical colleges can be included in the study. This kind of study is ethically also right. It may not be for this question, but if there is an intervention or a drug or an intervention which is life-saving, then everyone needs to get it. Possibly, as you move forward, as evidence generates, then ethically keeping it away or not providing it could be problematic. Logistically, you are not able to give the intervention to everyone in one go. You will go in for this particular study design. The problem with this study could be that the analysis is complex. So simple, straightforward analysis is not to be done here. There is multi-level modeling and complex study designs for which you will require a help of a statistician. And the second thing is, can a stepped wedge design be done within an institute, right? So can a teacher have batches and can they roll out the virtual dissection to batches in a step-based design? What do you all think? So there are, say, 5 batches. So the teacher says 1 month I'll just stick to one batch, then another batch, and I'll keep on adding and I'll use a step-based design. What will is that possible?
Yes.
Yes, it is possible, but there is a problem of contamination. That is, students who have experienced the virtual dissection can share their experiences and then make an attempt to explain to others, and that would contaminate the findings of the study. So within the institute, this kind of a question, it would be difficult, but different institutes, the risk of contamination would be less. So this is a very different kind of a study design, but still within the institute, there could be other research questions which could be taken up in this kind of a design. You can think over, if contamination is not likely to occur, then we can think of questions which can be answered using this design. But there was a specific question from the participant, and hence I have demonstrated this design and a question which would be answered using this design. Now we are coming to this question about perceptions, experiences, satisfaction. Now, many of you all rightly said that you would use qualitative research and mixed method research. Why did you say so? Why not do a quantitative study? Anyone?
Ma'am,
Yes.
if we are using only quantitative, we are not going to get the how and why of that. Like only with scores we will get whether the perception is good or bad. But if like only the number of it. But if we go into qualitative, we will also get to know the reason behind it, reasoning and their thought process behind it.
Okay. Anyone else? Right? What you're saying is right, Sumana. Any other thoughts?
Ma'am, in a quantitative approach, mostly all the questions will be designed by the investigator and only those would be answered. But in a qualitative approach, some new things which are not in the questionnaire, we are able to find out.
Correct. Right. Anyone else? I'm asking you all this question because this is something which is a bit difficult to understand.
We can generate 3 teams from this based on the findings in case of qualitative research, which ultimately leads to further research modeling.
Correct. Right. Yes. So more or less all of the respondents have answered correctly. So the research question which is answered by quantitative research is different, and what is answered by qualitative research is different. Now, I'll just share with you what I understand, because books mention it in different ways, but I have tried to understand it in a very simple way, that if you feel that there is a single truth out there in the world and you want to find out that single truth, quantitative method is what you should choose. If you are able to summarize that single truth in simple values, it is requiring quantitative research. But if there are multiple ways in which a phenomenon exists and there is no single way you can summarize that phenomenon, then you have to think of qualitative research, is what I look at the understanding of the difference between these methodologies. So I will try and explain to you with this interesting example. What do you see on the screen?
Where there is a bound wicket, but it is a different perspective which we see, but
So
a
if
different
I am
angle of
looking,
that.
yes, so if I am looking at it quantitatively, all I am looking at is that the batsman is out, right? The question is whether the batsman is out or not. There is only one truth, that the batsmen, all these batsmen, they are out. So this is simple quantitative. One truth, yes, out, right? But when I look at the qualitative aspect, now what happens? What I can see from the lens, the qualitative lens, is that one batsman is playing defensively, one batsman is shouldering or is leaving the ball, one batsman is frustrated with what has happened, another batsman is in the attacking mode and has been clean bowled. Then if I look at the stumps, somewhere I'm seeing that the ball has just kissed the stumps, somewhere it has broken the stump. The I can just expand this, and if you look at the commentary which comes with such kind of shots, so you can think of what would the umpire be doing, what is the bowler doing, what are the other team members doing, how is the audience reacting, the commotion out there. So when all these things come into the picture and all these things is what you are interested in, that is qualitative research, right? So there is no one single truth out here. There every time somebody is clean bowled, it's a different phenomenon. There is something different. There is no single way you can summarize what has happened. So that requires qualitative research, that is great descriptive text to describe what has happened. But quantitatively, it's just a number that this is out and this number is added to the number of people who are out in that team. So it is the numbers which we are interested in, quantitative. So you have to really understand that your research question, whether it is quantitative, the answer you're looking for, is it that single truth? Is it quantitative method? Or do you think you are interested in the phenomenon and all the description which goes with it and have a deep understanding of that phenomenon or that outcome? And there is no single way you can summarize what you're looking for. Then you will have to use qualitative methods. So I just want you all to understand. Now, for example, in this question, you are thinking of perceptions, experiences. Each individual will have it differently, right? Each person will have their own story to tell. So this kind of question is going to require a qualitative approach. So do you all understand what I'm trying to tell you? Yes? Aruna?
Yes, ma'am.
Thank you, Shahrukh. Aruna, are you with me? Monisha?
Yes, ma'am.
Thank you. So, again, to simplify, can I say that the average perception of the virtual deception table is so and so? The average experience of the first years? No, I won't be able to do that, right? So it really gives me a big hint that when I'm unable to do such a thing, I'm going to require qualitative research. An alternative, of course, is between the quantitative and qualitative is trying to do everything on a Likert scale and then use a non-parametric test. So this satisfaction, possibly you could say satisfaction level, and ask the person how you are greatly satisfied with virtual dissection compared to this and this, and ask them to rate the sentence on a Likert scale. This is something which is possible, which is something in between, a gray area between your quantitative and qualitative. So this kind of a Likert scale will give you such responses. So anatomage is a type of a virtual dissection table. And then you have this Likert scale, and you can clearly see that as far as the benefits are considered, many are agreeing strongly, disagreeing strongly, or just agreeing. While when you ask them about replacement, majority say no, virtual dissection is not a replacement for traditional methods. So you still get a sense of the satisfaction or what are their views about the virtual dissection using a Likert scale. But this is still different from a qualitative study. So this is again the same study, the parent study which I told you. They have done a survey at the end of their crossover, and they have used the Likert scale to assess the conceptual understanding, the perception actually of the students of conceptual understanding. So they have asked students about their understanding. They have not assessed their understanding. So this is their perception. on a Likert scale, and then they have compared here using an ANOVA and then post hoc analysis to find out the differences between different, because they have used multiple virtual dissection techniques, not just one tool, multiple tools with the donor category. So I will not go much here because we will be losing time, but again, this is an innovative way of actually putting up a graph and reporting your findings. This is a graph which is showing the average, the Likert scale or in the different types of dissection and comparing them using ANOVA. I just skip this, but again, I told you a purely qualitative study. Yes, this group has done a purely qualitative study on what? On teachers' perceptions, and acceptance of NHMH table. So what tools they must have used, do you think? For teachers' perception and acceptance, what tools for the qualitative study? I'm sure some of you know what qualitative study is all about.
Ma'am, they would have taken in-depth interviews.
Yes, correct. So they have used in-depth interviews and they have used focus group discussions, which were conducted in the teachers. And then the findings they have reported, as this is a taxonomic way of representing the themes. So what they have done not only the perceptions, but they have tried to find out what are the factors facilitating acceptance of virtual dissection. And the major themes they have found out is make it available, technology age, training opportunities, innovation, integration, awareness, and the drive. These are the factors which facilitate acceptance of this new technology. And they have tried to find out the barriers in terms of administrative constraints, attitudes, lack of awareness, cost constraints, electricity, installation needs, the student ratio, innovation concerns, then the cadaver-based culture, that is resistance to accept virtual dissection as the norm, training gaps, and curriculum. So here what happens, there is nothing. This appears to be grounded theory, where they have grounded their themes in their results. And then this is coupled with quotes, where they, in their own words, they say that people have said willpower of key stakeholders, hurdle of convincing institutional policymakers, resistance, all of which was for administrative constraints. So your in-depth interviews, your focus group discussions helps you to come up with these themes and sub-themes which you can present differently. So this kind of research question, research design is very different from a typical epidemiological quantitative study design. This is what I'm trying to say here. Then I'm coming to the health technology assessment, where the funders, the department is interested in cost effectiveness. So the issue here actually is the costing. How do you identify the costs? How do you measure the outcome, the effectiveness, and then the ICER plane? Can anyone tell me what is this? I'm sure some of you have been trained. Or you all have already forgotten what ICER is. I'm sure some of you, yes?
Incremental cost effectiveness ratio.
Yes, so this is incremental cost effectiveness ratio and the implications. Now, again, I'm not going to go in great detail, but some of you know it, some of you will learn about it, that these are the steps which need to be followed. This is the guideline for conducting reporting health technology assessment. My point of interest is here, how do you measure the effectiveness or the outcome? Because there are two things you want to really collect data on. One is the cost and the other is the outcome. That is the effectiveness, right? So your epidemiological study designs help you to come up with a value for the outcomes. So how do you select the outcome, measure the benefits or the harms, right? All of this is your the core epidemiological study. So again, costs, there are different kinds of costs, the direct, indirect cost, opportunity cost, which the data on which has to be collected for cost effectiveness analysis. The outcome, how do you measure the outcome? Do you all know what are the options for measuring outcome in a health technology assessment? In cost effectiveness especially, how will you get information about the outcome? From where?
Quality of life.
Okay, quality of life. Yes. So one, I'll give you a hint. One is you yourself do a study. So you may have to do, there is an intervention, a new intervention. You want to find out whether this new intervention is cost effective or not. For example, in this example, you have a virtual dissection table and you have the traditional cadaveric dissection. So we do a study. Now, if I want to do it in Grant Medical College, I will have to collect data on the costs incurred for that dissection table as well as for the cadaveric dissection, all kinds of cost. I will have to collect data. And outcome, for the outcome, I will do a randomized control trial as we have discussed, and I will get data on the outcome. So what is the grade, average grade of individuals in one group vis-a-vis the other group, and I will do my analysis. The question is, are there any other alternatives to get data on outcome apart from you yourself doing a primary study? So there are options. One is you search for a meta-analysis and you see whether a meta-analysis has reported on the intervention and the outcome. The second is you yourself do a meta-analysis. Instead of doing a fresh study, you know that many studies have reported outcomes for this intervention. You do a meta-analysis and get a pooled estimate of the outcome or the effectiveness. And the third is the decision trees or the models, different models, and using the probability at each stage of the model, which is used in the health technology assessment. The idea here, what I'm trying to tell you is health technology assessment is a very complex thing, but your epidemiological knowledge is important when you are looking at effectiveness. How are you going to measure effectiveness or outcome? Are you going to do your own study? Are you going to depend upon other studies and do a meta-analysis of those studies or summarize data from those studies? Or are you going to use some kind of a model and use the probabilities of shifting from one phase to another in different phases of those models is what you have to decide. And there your knowledge of epidemiology is helpful. So this is what I was talking about for the costs. Again, there is, you have to go through records or you may also look at literature and try and get the data on the costs which are incurred for different components. So again, this study has also been done, an approach to economic evaluation, and they have looked at the cost where they have taken the cost from, instead of just taking it from the institution, they have tried to get it from the literature because they wanted to get a cost which is applicable all over the country. The study was conducted in the United Kingdom. So data was obtained from published as well as grey literature and publicly available sources. And for the outcome, what they did is they synthesized the information which was available from meta-analysis and from a systematic review. So they have not done any study. They have just taken the secondary data and they have used this data to make a comment about the outcome. So again, what all costs were considered in this study? So there was cost for equipment, for material, for its maintenance, the depreciation cost, the durability of the material, and the personnel cost in terms of the staff fee, number of staff, the staff time, administrative staff, staff training, all these components, the information of which is necessary for doing a cost effectiveness analysis. And then they found out that for the virtual dissection, the total cost per student per year was 393 pounds. And for dissection, the cadaveric dissection, it was 436 pounds. And for the outcome, where I told you they synthesized the information from different studies. So they have got 3 different studies for cadaveric dissection, where the rating. So what they did was they read what was written, the text. And this was a bit subjective. They rated it. And from 1 to 5. So the rating they gave was 3, 3, 2, and 3. There were 4 in fact, and the average of whatever data was available was taken as the overall ranking for cadaveric and virtual dissection. So the overall ranking for cadaveric dissection was 2.75. For virtual dissection table, it was 4. So this is the effectiveness. They have not done a study. Based on reports, they have come up with some ranking or from some score for cadaveric and virtual dissection. And then of course, yes, yes, please.
Now, is it similar to the grade approach they use for quantification of papers, or it is some different thing?
Yeah, what they have done, no, they have read the result section and what has been written about cadaveric dissection and about virtual dissection, and then subjectively they have said that depending upon what has been written in that particular, say in the meta-analysis or the systematic review and the other few articles which they refer to, they have started from the score 3. If it is positive which has been written, they have upgraded the score, and if something negative has been written, they have downgraded the score. And
there is this
yes,
same grade approach we use in after meta-analysis to quantify the study.
Somewhat same, but not so objective.
Okay. Okay.
Not so objective. Yeah.
Thank you.
Yeah. So they have now information about the cost, they have information about the effectiveness, and then they can go in and calculate the ICER, and they can plot. So this hourglass, which is the brown colored hourglass, that is the point where they are comparing the virtual dissection with the cadaveric dissection. So can you interpret? This is the ICER plane. And I know we are going away from our topic a bit, but I don't know if anyone is interested in this, but I have showed you the cost difference as well as the effectiveness difference. Using that, you can find out what is the cost for a 1 unit increased score in the learning outcome. And based on the ICER, it is in the 4th part of the ICER plane. What does this indicate? That it is not only more effective, but it is less expensive, the virtual dissection compared to the cadaveric dissection. So the findings are going in favor of the virtual dissection. So to answer this research question, that is whether it is cost effectiveness, a very specialized approach, specialized training is going to be required, and this is a very different kind of a study design. So the study design is something very different, and only a small part of which is your quantitative epidemiologic design. So any questions till now?
I have a question mark.
Yes, please.
The time to event study
Yes.
we had mentioned regarding hazard ratio. Are there any other outcomes which we have to see in that slide?
No, in
other
time,
than hazard?
Yeah, in time to event, usually you are interested in hazard. You can be interested in cumulative hazard. You can calculate your Kaplan-Meier curves, and you can compare the curves and see whether the time of occurrence of the events is the same or is it different. But the primary outcome for time to event analysis is the hazard. The hazard is nothing but the instantaneous risk of occurrence of the outcome. So every time the time changes by a unit, how does the risk change? How much does the risk change? So it is like the risk. When the hazard is more, the risk is also invariably going to be more. But the hazard ratio helps us to find out the time of event, whether the events are occurring the same in your intervention. The timing of the events is the same in the intervention and the control group. So when you're interested in survival analysis, you go in for time to event and your hazard ratios. Sweta, ICER, I think we will do it in our department separately. So I will not go in detail because actually our objective here is to understand the plethora of the study designs, and your research questions need to be answered using different studies. That sense you should get here that there are different options out there. Quantitative is one, qualitative is one, health technology assessment is altogether another ball game. So depending upon what question you're trying to answer, you have to think differently. That is our objective. Any other question? Somebody asked about time to event. Remember, you can use cohort studies, retrospective cohort studies, intervention studies for doing your time to event analysis. There are a few other things. I don't know whether Nishant is not there. He had put forth some questions which I am going to just answer because it may benefit some of us. He had asked about difference between academic and regulatory trials. Academic clinical trials. These are the trials which are initiated by investigators and scientists in institutions and not by pharmaceutical companies or by industries. They are done for new indication, new routes of administration of the drugs which are already being used, or new dose or new dosage forms. These kinds are known as academic clinical trial. So they will not need approval from the central licensing authority. I have mentioned two references below. If anyone is interested in this, they can read the references in detail. So I will not go into the details of an academic clinical trial. Another question which was put forth was, if there are multiple objectives in a study, you will use multiple study design. So what to do? So for your sample size calculation, sampling technique, you can stick to your primary objective. You can embed studies or nest one study into another study. You can use mixed methods like the quantitative, qualitative. And when you have multiple study designs, you can conduct the study in a phase-wise manner, one followed by the other. So you can use multiple study designs, but you can then put them in your proposal in a proper format. And each one will then require different sample size sampling technique. Of course, this I'll just skip. If anyone is interested in this violin plot, I have just shown you. This is something very similar to your box and whiskers plot. The box and whiskers plot just helps you to present your median. It tells us about the whether there is a skewed distribution, a symmetry that is, and an outlier. Can you all tell me what is the additional thing which a violin plot tells you compared to a box plot?
Variance.
Sorry? Somebody said something. Variance? Did you say variance? So what this violin plot does, it just tells you, gives you the density or the probability distribution, what is known as kernel density plot. So where the violin, where it flares out, where the frequency is more, and where it is narrow, the frequency is less. So more number of observations are there where this violin just spreads out. So you know what kind of distribution this is. So in this case, you know that majority of the observations are near the median. And you can put in your box and whiskers plot within the violin, as has been done here. So you can show the median, you can show the median mean differently, as I have showed you earlier in one of the results. Of course, the outliers are not shown as dots, but whenever it thins out, you know that there are outliers along those lines. And the most interesting thing is this particular graph, which shows you that box and whiskers plot may be the same, whether say the distribution is bimodal or uniform, but it is clearly shown in the violin plot. So the violin plot actually is nothing but a histogram, a frequency curve on the histogram, and a mirror image of that frequency curve. So it is symmetrical and it really helps you to understand the distribution better. Box and whiskers plot has its own strengths, but the probability distribution is an additional feature of the violin plot. So these plots, if you see anywhere in any studies, don't be afraid to interpret them. Look at them carefully. They are easy to interpret because they have a box plot within them. The only additional feature is the probability distribution, the frequencies of. So you can see that in the first bimodal, as expected, there are two modes. So there are two bulges which you can see, where in the uniform distribution, the observations are distributed uniformly without two curves. So those differences are captured in the violin plot. This is something Sorry? So this is something which you can look up and you can use in your research. So I think this was my last slide. Now, if